But what happens when the variables aren't that neat? When the numbers don't add up? Or worse, the math was flawed from the start? Today, we're taking a fresh look at how we define wellness, not just as the absence of disease, but as something more whole, more human, and more inclusive. We begin with health equity, the foundation without which no version of wellness is complete. Because no matter how advanced our treatments or how well-intentioned our advice, if people don't have access to care, then the system isn't just incomplete, it's unjust. Health equity asks us to look beyond the individual and into the structures that shape our lives. Then we'll turn to the body, and specifically to obesity. It's a topic that's been loaded with stigma, confusion, and blame for far too long. But science, policy, and public conversation are beginning to shift. We're seeing obesity not as a moral failure, but as a complex chronic condition. And as our speaker will explore, treatment and understanding are evolving accordingly. Finally, we arrive at the mind, not as an afterthought, but as an integral part of the wellness equation. So much of the conversation around health is finally catching up to what many have long known, that mental health isn't separate from physical health. It's not a luxury or an add-on, it is foundational. The rising rates of anxiety, burnout, and depression are not just headlines, they are a call to rethink how we care for the mind as an essential part of overall well-being. So today's speakers will each help us reframe what we think we know. They'll challenge assumptions, bring in new data, and I hope offer us all a richer, more realistic picture of what it means to be well in today's world. We'll hear from each speaker, and then we'll have time for discussion at the end. So please jot down your questions and thoughts as we go. We want this to be a dialogue, not just a download. With that, I'll hand it over to Dr. Shanaz to introduce our first speaker.
Welcome to everyone. I'm going to start by introducing our very first speaker, Saifra Khan Sohail. Saifra Khan Sohail is a public health researcher and a strategist focused on advancing health equity through ethical research, inclusive program design, and cross-cultural collaborations. Her work bridges academic research and community impact, spanning digital health, social behaviors, global monitoring system. She has over a decade of experience across nonprofits, universities, and industry, and she holds a Master of Public Health degree from the Johns Hopkins Bloomberg School of Public Health. So let us welcome Saifra to the podium. She will speak about health equity and access.
How do I get my slides to come up? When that should come. There we go. Good? Okay. Assalamu alaikum. It's an honor for me to be part of this panel as we rethink what it means to foster wellness in our work and communities. So we will be hearing insights into obesity and mental health, two issues that dominate the wellness discourse. My fellow panelists will focus primarily on individual level interventions during their talks. I want to start by zooming out and not just focus on what individuals are doing, but what systems may be enabling or keeping them from doing. What if the wellness equation we're using is missing not just one variable, but several? I believe that the missing variables are the factors that create health equity, and without it, sustainable wellness cannot exist. So when we talk about our health and wellness, we rarely pause to ask, where does wellness actually begin? An experience I had while conducting public health research in rural Guatemala prompted me to ask myself this question. So I sat in a small home during a research training. You can see a photo of what I observed here on the slides. This home had no floor, just packed dirt. Chickens wandered freely in and out of the home. There was a barefoot toddler wandering around them, and his mother, who was alone and managing several children by herself, tried to prepare a meal. There was soap, it sat high on a shelf, but there was no running water inside this home. And the child was already showing signs of their growth faltering. So this was not a case of caregiver negligence. This was a case of systemic absence. The mother told us clearly she knew the importance of hygiene. She wanted her child to thrive, but she lacked resources, safety, and support. That moment clarified something for me. Wellness does not begin in a clinic or a doctor's office. It is not just about our physical and mental health. It begins with the structural conditions into which people are born and raised. So what exactly is health equity? The CDC defines health equity as the conditions in which everyone has a fair and just opportunity to attain the highest level of health. So this definition here says fair. It does not say equal, and as you can see in this image here, equity acknowledges that there have to be unequal starting points in attaining the highest level of health or wellness. So when we assume that everyone is starting from that same baseline, whether we're doing research, treating patients, managing health programs, we risk reinforcing inequities. Equity requires that we are making proportional investments based on our target population's realities. And so for professionals designing care models, public health programs, or health education, equity means asking, whose reality does this intervention activity program assume? And who gets left behind when we universalize that model? Because the same treatment will not always result in the same outcome. So let's go back to rural Guatemala for a second. The results of this study, which included household observations and in-depth interviews, found consistent structural disparities between the households of stunted and non-stunted children in the communities that we studied. And so stunted, just for the sake of definition, the child is malnourished and they have a low height for their age. And so we found that the stunted children were more likely to live in homes with unsafe flooring, open defecation, and indoor livestock. The caregivers of these children had fewer support systems, lower educational attainment, and more domestic burden. But what was most striking was actually what was not different between these two groups. Their mothers or caregivers had knowledge about health and hygiene. They knew what they needed to do. They expressed immense love and concern for the child's well-being. This confirmed what many of us already know. The environmental and systemic constraints are often a major limiting factor. That space between what people know and what they can consistently do is where health inequity lives and grows. But is it really about their choices? We often frame their health interventions, especially in medicine, around the concept of personal choice. These Guatemalan mothers, they knew the importance of hygiene. They had absorbed the health messaging that was provided by clinics and international nonprofits. Soap was present in nearly every single home. But water, not reliably available. In some cases, they had to walk miles to access it, and when they got there, that water wasn't even safe. Add to the fact that these mothers were often managing several of their young children by themselves with minimal family support. So they knew what they had to do, and they technically had soap, but they couldn't always act on that knowledge in a consistent, safe way. So again, it's not a question of individual choice here. That's a question of structural availability of time, resources, safety. People cannot choose options that they don't actually have access to. So when we talk about lifestyle change, behavior change, non-compliance, in our interventions or research, we have to be honest. Many of those variables we are asking people to control are in reality beyond their control. And so this is why health equity matters. It reframes the conversation from individual willpower to structural support. And so this brings us to a very critical concept that some of you may already be familiar with, but it's one that should stay in the front of center in every conversation about wellness: the social determinants of health. The social determinants of health are defined by the WHO as non-medical factors that influence health outcomes, things like where we live, what we eat, how safe our environment is, and what kind of social support we have access to. According to the National Academy of Medicine, health is determined much more by social, behavioral, and environmental factors than by healthcare services alone. In fact, only about 10 to 20% of your health is actually affected by your medical care, they found that up to 80% is determined by what's happening in your everyday life. So just walking quickly through this conceptual graphic, at the outermost layer, we have the macro systems, policy, governance, economic structures. The next layer includes institutions and sectors like education, housing, and health systems. And then we have community level factors, transport, food access, social capital. And then at the center here is the individual and the individual level factors. But what we end up doing is we are largely focusing on the inner ring. If we want to understand why wellness looks different across populations, we have to look at what is surrounding the individuals, not just what's inside of them. So in the Guatemala example, the child stunting, it wasn't due to the maternal behavior. It wasn't due to his mother's behavior in this inner circle. It was shaped by poor sanitation infrastructure, economic precarity, and social isolation. So when we're ignoring those upstream determinants, we're placing a disproportionate responsibility on the individual, especially with those with the fewest resources. These inequities that we're seeing are not unique to Guatemala or the global south. These structural patterns in Guatemala are mirrored across the US in different forms. Research has found that in many US cities, your zip code is actually a stronger predictor of your lifespan than your genetic code. And a couple examples I'll share is in DC, in Washington, DC, there's actually a 20-year life expectancy gap between neighborhoods that are less than 10 miles apart. Food access research has found that predominantly Black and Hispanic neighborhoods have less access to large grocery stores, healthy food is more expensive and harder to find, and there are actually more dense clusters of fast food stores, and they're actually near schools. And this is referred to as a food apartheid. It's actually not a food desert, because all of these patterns are not accidental or natural. They're a result of intentional zoning laws and policies. Another example is that only about 33% of Black adults in the US with mental health needs actually receive treatment, compared to over 50% of white adults. And again, this treatment gap is tied to cost, stigma, access, mistrust. None of these outcomes are random. These all exist as a result of intentional policy and are continued to be perpetuated through practice. And these US-based examples should remind us that this health inequity is not just a global issue. It's not just something we see on a medical mission. These are things that are deeply embedded in our own neighborhoods, our own communities, our own patient populations, our research studies, and it requires us to reimagine the very foundations of the wellness equation. So I'm going to talk a little bit about how we could rethink this wellness equation. Traditionally, wellness has focused on mainly personal health, our body and our mind, and I think for the sake of the panel, we also included medicine. But true sustainable wellness is far more complex and interconnected. We can't just look at these individual factors of physical health and disease prevention and emotional, mental, and well-being. We also have to take into consideration the environment we live in, the support and strength of the communities we belong to, and the justice of the systems around us. And it's supposed to say environment up there, which is, it's missing from there. So this holistic approach is essential to advancing health equity and improving outcomes for all. Those choices that we often focus on are only sustainable when the conditions support and enable them. So recognizing justice as part of this equation, it's a fundamental part of wellness, and it's reminding us that equity is not optional. It's a responsibility that is rooted deeply in our values and beliefs as Ahmadi Muslims. In Surah Al-Ma'idah, verse 9 of the Holy Quran, Allah commands us to uphold justice steadfastly, regardless of challenges or enmity. And by applying this guiding principle to the context of our work in wellness, we are all called upon to speak up and actively address and dismantle these systems that create and perpetuate health inequities. So where do we go from here? Where does this leave us as people who are working in health, in research, and policy? So what now after listening to this talk about health equity? I ask you all to consider the following in your work. Expand your lens. Ask yourself, who is this intervention really designed for? Is there a barrier that is invisible to me, the provider, in this treatment plan? Engage community voices. Let people define their own needs. Don't just consult with communities, but actually co-create with them. Create mechanisms that transfer power and leadership and not just information. Think systems, sustainability, and service. Who or what is the upstream of this health issue? Will your intervention last beyond this grant cycle or the funding? Are you extracting data or are you building trust? Decolonize your research questions, decenter your assumptions about a population. Share your power and the privilege that Allah has granted you, because at the end of the day, our roles are not neutral. We are shaping systems every single day, and wellness is not wellness if we leave people behind. When we build for equity, we build for everyone. Jazakallah.
Thank you, Saifra. We will continue with our next speaker, Mansoora Bhatti. Mansoora holds a bachelor degree in human nutrition and dietetics and a master's in food science. She has spent 10 years working as a nutrition support dietitian in critical care and ICU settings, including 4 years of clinical leadership and advanced certification in neonatal nutrition. More recently, Mansoora has earned her certified diabetes care and education specialist credential, and she currently works at the Bariatric Surgery and Metabolic Center at Houston Methodist Hospital. Outside of work, Mansoora enjoys running and traveling, and she has completed the Houston Half Marathon last year. But she's also active in the community in many leadership roles and has recently served as the president of the Greater Houston Dietetics Association, and she volunteers locally to teach culinary classes to the people in her community. So we would love to welcome Mansoora Bhatti, and she will talk about tackling obesity.
Assalamu alaikum. Okay, so I'm going to be discussing obesity today, and I want to start by asking all of the clinicians, when I say the word obesity, what does that make you think of? What thoughts, what words, what experiences come to mind? And we're going to come back to that at the end of our presentation. So in terms of diagnosis, we diagnose obesity through a BMI of 30 or above. So BMI is a good screening tool, not the best, but it's a good screening tool because it doesn't look at body fat. So obesity is chronic, progressive, relapsing. It's a disease that's characterized by excessive body fat. And BMI just looks at total body weight. It doesn't specifically look at fat mass. So I just want to, so this is going to be basically looking a little bit more closely at our classes of BMI, right? So we start with class 1, which is a BMI of greater than 30. And the reason for those classes is basically treatment. We're going to treat usually surgical interventions after BMI of 35 or above. And then typically we get pharmacotherapy treatment whenever it's a BMI of 30 or above. Okay. And so I do want to draw your attention to this map and see how obesity has increased over the last 10 years. So the more red or the more orange that this map is, it shows a higher prevalence in that state of obesity. So if you look at it, this is that last map was 2013, this is in 2023. So it's kind of lit up in red, right? So we see that obesity has significantly increased, and especially particularly from 2017 to 2021. Okay. Now I'm going to just talk a little bit about the social and the economic impact of obesity. So weight stigma and bias do affect care. So when we have weight stigma and weight bias, it usually delays our patients receiving treatment. It usually affects their mental health, and it has usually strained patient and provider relationship. And stigma, our biases usually lead to a stigma, and stigma ultimately leads to discrimination. And this is not a protected class. So patients with obesity are not a protected class. So they can't necessarily fight whenever they have been discriminated against. And they do have prejudices in education, workplace, and healthcare. And just to give you a little bit of an idea, patients with obesity earn 15% less than their normal weight counterparts. So it does affect their self-esteem and their quality of life. So is obesity a choice or is it a disease? So this is something that I want to come back to in just a little bit, but just something for all of us to think about. So we do have multifactorial causes of obesity. So obesity arises from a complex interplay of biological, environmental, and physiological factors. Basically, Saifra talked a little bit about an obesogenic environment. So when it comes to our environment, when we do have limited access to healthy foods, limited spaces for physical activity, and limited access to healthcare, that is going to make you more prone to become obese. And there is a genetic predisposition to having obesity. So, one analogy that a physician used is that, genetics loads the gun and environment will pull the trigger when it comes to developing obesity. I'm going to spend a little bit of time on this slide. So we're going to look at the pathophysiology of obesity. So obesity is not just a matter of fat accumulation. There is hormonal imbalances, there's chronic inflammation and dysregulation of your metabolism. So when we have excessive body weight, such as, increased fat mass whenever patients have obesity, it usually drives inflammation. And the reason why is because those fat cells in patients with obesity, they look different. They're a different size, they're a different color, and they're usually pro-inflammatory, and they contribute to insulin resistance. So because of this, fat in patients with obesity is an endocrine organ. And also leptin. So leptin is a hormone that we produce that signals fullness in our brain. In patients with obesity, the brain doesn't respond to leptin, and so they don't feel full, they don't feel satisfied. They continue to feel hungry despite consuming adequate calories. Because they continue to feel hungry, they have a tendency to overeat and gain weight. Another concept is metabolic adaptation. So why is it difficult for these patients to lose and maintain weight? It's because of a concept called adaptothermogenesis or metabolic adaptation. So what this basically is that larger bodies need more calories and smaller bodies need less calories. So after weight loss, our bodies require less calories to maintain that weight. So basically our metabolic rate decreases as we lose weight. So our metabolism is slower and our body doesn't burn calories as efficiently. In addition to that, as they lose weight, our hunger hormones start to increase and our fullness hormones start to decrease. So it really sets the stage for weight regain. There are obesity-related comorbidities, as we know. So obesity is associated with serious conditions such as cardiovascular disease, hypertension, dyslipidemia, diabetes, and sleep apnea. There is a higher risk of certain cancers like colorectal, breast cancer, ovarian cancer, and renal cell cancer. So I'm going to go back to the question that I asked before. So is obesity, so basically based on what I just went over, is obesity a choice or is it a disease? The American Medical Association designated obesity as a disease in 2013. Again, it's because of our high body weight, it does impact our overall health. And so there is a chronic component, and that's those hormonal changes that I talked about. It is progressive, because I talked about the inflammation process, and it's relapsing. We talked about metabolic adaptation. So there is an interplay of genetics, environment, and biology when it comes to obesity. Okay, now we're going to look at treatment options. So we always want to start with the lowest risk option when it comes to treatment. So we always want to start with lifestyle interventions. That's diet, exercise, sleep, stress management, and looking at those. And then we start pharmacotherapy. And then the last one is bariatric surgery if we need it. I'm going to keep coming back to this verse in the Holy Quran where it says, and eat and drink, but exceed not bounds. Surely he does not love those who exceed the bounds. And this is basically talking about, what we're eating, right? There's also a hadith in which the Holy Prophet says that when you eat, 1/3 of your stomach is for food, 1/3 of your stomach is for drink, and 1/3 of your stomach is for air. So nutritional considerations. So when it comes to lifestyle modifications, we do want to look at the quality of our diet. So it's not necessarily just calories in, calories out. It's, we want to prioritize where those calories are coming from. Control portion sizes. So again, we go back to that theme of exceed, not bounds. We really want to look at portion sizes when it comes to what we're eating. We want to limit those pro-inflammatory foods that have added sugars and unhealthy fats. We want to look at meal timing and satiety. A lot of my patients with obesity will only eat one meal a day that's highly caloric, so really looking at when we're eating and how much we're eating at those meals. Hydration is important because water is an appetite suppressant. When we're drinking more, we're less likely to eat as many calories. Sleep. So actually while we're sleeping, we're producing that fullness hormone, leptin, and so if we're not sleeping adequately, we're not producing that hormone. Stress and mental illness. This will really play havoc on our body, so once we start addressing the stressor, we're able to manage weight with these patients. I do want to draw your attention to the pyramid. So that pyramid shows that, lifestyle interventions is really the foundation. So whether you choose to move forward in terms of pharmacotherapy or surgery, we always need to have that foundation of lifestyle and nutritional interventions first. So weight loss medications, we're going to talk a little bit about the mechanism of action. So these medications work to suppress our appetite. They increase the feelings of fullness and they decrease hunger. They're going to slow gastric emptying. So food is going to sit in your stomach longer. You're going to feel more full throughout the day. And the third thing that they do is they improve our blood sugars by stabilizing those blood sugars after meals. The two things that I want to remind you about pharmacotherapy is the indication. So we want to make sure that these patients are at least have a BMI of 30 or more. And the other thing is if they do have a BMI of 27 and have a comorbidity that will improve with weight loss, then that's an indication for the use of these medications. And the other thing is tell your patients, if you're going to start these medications, plan to stay on them for at least 18 months, just because they're a good tool for weight loss. But once we take away the tool, then we have a risk of weight regain. I just want to compare a few of these medications. The two that we see most often is the semaglutide and the tirzepatide, and it has kind of the hormones that they mimic and also the weight loss. So the percentage of weight loss when it comes to pharmacotherapy is usually between 10 to 15%, 10 to 20% really, and for lifestyle interventions it's about 5 to 10% weight loss, so you're getting more weight loss with these medications. The exciting thing about this one that's coming out in 2027 is this medication is preserving more muscle mass, so we're not seeing as much muscle loss with these patients that are going to start on this medication. Okay. And then we've got surgical intervention, so bariatric surgery. So again, exceed not bounds. What these surgical interventions are doing is they're decreasing the surface area of the stomach, so you're eating less, right? The two that we're seeing most often is going to be a gastric sleeve or Roux-en-Y gastric bypass surgeries. And then Saifra talked a little bit about community. I do have a really good story about a patient that was actually utilizing community gardens, but we'll go over that if we have enough time. All right, so biases and barriers to care. So I want to come back to that question of what are your thoughts when you think of obesity. So kind of, thinking about what thoughts, words come up. I do want to take a look a little bit at bias and barriers. So there is weight stigma among providers. Providers typically see patients with obesity as non-compliant, dishonest, lazy, weak-willed, unintelligent, and sloppy. There may be inadequate training and support for these individuals, right? They usually, healthcare providers spend less time counseling them. They inherently believe that patient may not comply. And sometimes when it comes to the patients, they delay, seeking out healthcare. They have negative experiences and feelings, and they may have worsening health and maybe some comorbidities related to that. So it is important for us to have weight-inclusive and respectful care. You want to make sure that you emphasize, behavioral change versus focusing just on the weight itself. We want to create a culture of support and compassion, having larger size chairs in your offices, larger gowns, larger blood pressure cuffs. And then know that when you have an implicit bias, your patient is going to pick up on that. So I want to draw your attention to this verse as well. So do good to others as Allah has done good to thee. So sometimes we lose sight of the fact that the roles could very easily be reversed. We could be the ones on the other side of that consult room. If it wasn't, if it wasn't Allah's grace, the genetics that we were born into, the opportunities that we had in life, the education that we were provided, we could be the patient. Honestly, just check your bias. So I just want to end with rethinking the wellness equation. So I want to focus on the role of nutrition when it comes to the wellness equation. So nutritional care serves as a critical connection between the mind and the body. In a patient with obesity, dietary patterns will influence their metabolic health. But it's also going to impact their emotional health. So Sana's going to talk a little bit about the gut-brain axis. When we eat better, we're going to feel better. It does impact our gut microbiome, and it enhances our production of serotonin. So, there is both the psychological and a physiological component when it comes to dealing with patients with obesity. So we want to make sure that we're focusing on those nutritional interventions. And just making sure that we're educating ourselves. If you do want to go online, there is an implicit bias test that healthcare workers can do just to check your own bias. Jazakallah.
Thank you, Mansoora. We will now move on to our final speaker for this afternoon, Sana Rehman. She's a licensed professional counselor in Texas with 5 years of telehealth experience, serving a diverse, primarily, let me see if I can say this, Black, Indigenous, people of color, and first-generation clientele. She holds a bachelor's in psychology from Texas A&M University and a master's in counseling psychology from the University of Houston, Victoria. She's originally from College Station, Texas. Sana is dedicated to providing culturally sensitive care with a focus on high-functioning anxiety, complex trauma, and worried about the mental health experiences of eldest daughters and immigrant communities. So let us welcome Sana to the podium to inform us about mental health in the modern world.
Assalamu alaikum. My name is Sana Rehman, and I'm really grateful to be here amongst so many experts in these valuable fields. Oh, wait, we're going that way. So I'm a licensed therapist, and my work focuses on helping people navigate mental health in the modern world, a world where constant stress and being on alert have become the norm. In my practice, I work with people navigating trauma, perfectionism, and high-functioning anxiety, many of whom look like they're doing completely fine on the outside, but inside are really burned out. What I've come to realize in my clinical work is that we can't treat mental health in isolation. Mental health symptoms are not always mental in origin. So today I want to challenge all of us, especially those in the patient care space, to rethink that wellness equation. So for too long, we've pathologized symptoms that are often physiological responses to modern life. So anxiety from chronic stress, poor sleep, and constant nervous system dysregulation from addictive habits like doom scrolling on our devices. I hear so much self-blame from my clients, guilt over being anxious, shame about not being grateful enough, and a lot of my work is actually centered around deconstructing shame. A renowned sociologist, Dr. Brené Brown, says that guilt can sometimes be useful. It can help us recognize where we've fallen short. But shame convinces you that you are the problem. It isolates, it erodes self-worth, and often the shame is the very thing that fuels the behaviors you're trying to change. So I always tell a lot of my clients there's no place for shame in your life. Right now, we're seeing record levels of stress and burnout across the country. There's a Harvard physician, Dr. Aditi Nerurkar, who has really valuable research on stress, and she distinguishes between two types of stress. So there's healthy stress, that's the stress that motivates, it moves your life forward. And then there is maladaptive stress, and that's the type of stress that can leave you feeling paralyzed. Now, thinking we're going to get rid of stress completely is just plain unrealistic. It would be nice, but it probably won't happen. So what we can do is help reduce the maladaptive load that people carry every day, and that starts by simply making them aware of these topics. Teaching them while reminding ourselves that we need to prioritize rest as a biological necessity rather than a nice-to-have luxury. So I wanted to talk a little bit about the gut-brain connection, as Mansoora mentioned. Your gut isn't just a digestive powerhouse. It's actually, it houses up to 95% of your body serotonin production. It is also home to the second largest network of neurons, second only to the brain. So this means that your gut and brain are in constant dialogue, influencing each other through a powerful feedback loop. When you're under chronic stress, your gut's gonna feel it. When your gut is out of balance, it can tank your mood, your energy, and your emotional resilience. Supporting gut health isn't just about digestion, it's a key step in restoring balance to the entire mind-body connection. Okay, so we've established the connection between health and nutrition. However, your mental health is also deeply intertwined with your sleep and your movement and your nervous system regulation. If your nervous system isn't safe, your mind isn't going to feel safe either. Our fight or flight response was never designed to run 24/7, but for a lot of people, for a lot of my clients at least, that's how it feels. Dr. Ranjan Chatterjee is a British physician and the author of the 4-Pillar Plan. He's really impacted my work as a therapist. He emphasizes the importance, as you'll see on the slide, of your food, your movement, your sleep, and your relaxation habits, and how improving these over time can lead to better overall wellness. And we'll come back to these pillars shortly. I want to share a case from my practice, one I see often. So she's the eldest daughter in a Muslim household, a role I see very often, especially among first-generation and second-generation clients. She was trying to navigate college with an intense internal pressure to perform while trying to balance familial responsibilities and personal relationships, and the compounding pressure of all of that led to anxiety attacks and chronic stress. When we zoomed out, we noticed a clear pattern. There was excessive caffeine intake, erratic meals, doom scrolling late into the night, and then no safe outlet for her to be able to process some of these thoughts. So her body wasn't necessarily sick, but it was stuck in what we call survival mode. And here's the thing, so many of my clients especially want to have the solution. They're like, okay, so now what do I need to do to feel better? And they just want me to give them the solution so they can move on. Again, high functioning clients, right? A lot of us can probably relate to that, but we need to make the awareness the first step. And so I think that's the main area my work focuses, is just raising awareness to the alarm bells that are going off in the body. So I often bring up the concept of 1% changes with my clients. It's a idea from a popular book, Atomic Habits, and that idea is that small incremental improvements, when compounded over time, lead to significant results. And in this client's case, we worked on stabilizing her nutrition, cutting back on caffeine, creating a proper wind-down routine that helps promote better sleep, and these changes combined with regular therapy helped her symptoms decrease significantly. Now, I'm not a dietitian or a sleep coach, but more than I ever imagined I would discuss with my clients when I first started training as a therapist, my work greatly overlaps with those pillars we just discussed. So if your food, your nutrition, your movement, your relaxation habits are out of balance, that entire system is going to suffer. Therapy is powerful on its own, but it's even more effective when we pair it with education about the body and how small, sustainable shifts can have a huge effect on the entire system. And I want to take a moment to speak on the importance of normalizing mental health care, especially in communities like ours. It's actually one of the main reasons I agreed to speak today, because I wanted to destigmatize the idea of therapy. And I go over this in almost all of my consultations with clients that are often a bit weary because they are still navigating the cultural stigmas around mental health. Therapy isn't just something to turn to in a crisis. It can be a part of a very healthy, regular self-care routine, similar to other services that we might schedule for ourselves. It's maintenance for your mind, your emotions, and for your nervous system. And therapy is just one tool in that toolbox. It's more powerful when paired with lifestyle shifts and education about the body. So I wanted to take a moment to relate this to our practice as Muslims. When we talk about nervous system regulation, we're also talking about something spiritual, how we anchor ourselves in something that is bigger than us, and how remembrance creates physiological ease. So one of my favorite verses in the Quran is, "Verily, in the remembrance of Allah do hearts find rest." This is one of the most direct references to emotional regulation in the Quran. It reminds us that spiritual remembrance is rhythmic. It slows the breath, it quiets the mind, it co-regulates your nervous system. And the point is, when we're anchored in something deeper than our stressors, we actually find true rest. So, if you remember one thing from my presentation, it's this: mental health isn't just in your head, it's in your habits, it's in your nervous system, your food, your relationships, and your rest. These are the foundations I try to integrate in nearly all of my sessions. I return to it often. I know my clients are sick of me asking them about their 4 pillars, but I really believe it's that important. If one of these are out of alignment, it can throw off the rest. But the reality is that all of these symptoms become even more complex when layered with barriers to care, as you've heard earlier. Stigma, cost, cultural disconnect, and then lack of access to quality care really disrupts a lot of people from even getting access to the care, but it also keeps them from reaching out again if they've had a bad experience. And I really, really hope that collectively we can step beyond seeing people as their diagnoses and start seeing them as ecosystems shaped by both their biology and their environment. Jazakallah. Thank you so much for listening, and these are a couple of resources that I might have alluded to earlier, in case anybody wants to take a picture. Thank you.
Is that mic working? Can you check? Oh, no, there is no mic. Can you check if that's working? I don't think they are setting it up for us. Do you all have? No? So we can just do it from here.
Jazakallah to all of our speakers. Thank you for your incredible insight and the work you do every day. Thank you all for being here. At this time, I think it would be a good time to open up the floor for QA. We might be having some issues with the microphones. If you are comfortable, you can come up here to the mic. Otherwise, you can ask your question where you're sitting, and I can broadcast it out to everyone else. As far as the men's side is concerned, we are being broadcast over there. I hope there's someone there to facilitate if there's any questions. I did hear a lot of buzz, so either they're really into this session or they were ignoring us entirely. I guess we'll find out. Does anyone have any questions? Would anybody like to start? Yes, please.
So this one is for Mansoora. So patients on GLP-1 agonists, what do you recommend in terms of their diet to reduce muscle mass, and what do you usually recommend to those patients?
For Mansoora, do you want to repeat the question as well?
So, Assalamu alaikum, thank you. Dr. Sadia Nawal asked the question of what do I recommend in terms of nutrition for my patients on GLP-1s. I love this question because I usually ask the PCPs to just, whenever they're going to start a patient on a GLP-1, just send me a referral. Just let me see all of your patients on GLP-1s because there's so much that they need to know about diet. So really, the side effects that we're seeing with a lot of these patients is nausea and constipation. That's probably the thing that we're seeing most often, and then loss of muscle mass. I do body compositions in our clinic, so we actually see that the muscle is being lost or that they're preserving muscle mass. And the way that we preserve it is by making sure that they're getting enough protein. So I recommend at least 20 to 30 grams of protein per meal is what I'm trying to get them to do. They don't always do it, but even if I can get, anywhere from 50 to 60 grams of protein per day, we're doing really, really good. So that's what I usually recommend in terms of protein. 3 days of resistance activity. So I just say 15 minutes for 3 days a week of resistance activity, and that can be weights, that can be bands, that can be, using your own body weight as resistance. So that's what I usually recommend in terms of preserving muscle mass. Several small meals throughout the day, so just keep, eating, because you're only going to be able to tolerate a very small amount because of that nausea. Because, you've got delayed gastric emptying. Food is sitting in your stomach, so it's going to want to come back up, so you may feel nauseous. Usually we see the most pronounced effects during dose escalation. So whenever they go up in their dosage, that first 1 to 2 days is when they see the most pronounced effects. So I hope that answers the question.
Any other questions from the audience? Yes, yes, please.
So this one is for Senator Rehman, is in terms of, so I know there's the gut health in terms of depression, anxiety. Do you know any research about how SSRIs have improved gut health and what the mechanism of that would be?
Honestly, on that one, I'm not as informed as Mansoora, but do you know how it affects the gut with SSRIs or medication? Because I know even GLP-1s can affect mental health as well.
Yeah, so all I'm going to say about that is that, as patients are on medication, it does mess with their gut microbiome. Just because of that.
I'm sorry, I should have done that. I'll go up there with you actually and finish answering. Okay.
So the question was, how do SSRIs affect your gut microbiome? I will just say when it comes to medications, typically they are going to reduce the amount of good bacteria that we're producing in our gut. And usually with that, high fiber diet is what I usually recommend. The more fiber that you have coming from beans and whole grains, fruits and vegetables, the more good gut bacteria. And I just don't mean like just eat apples all day. No, you've got to have as much different and variety of fiber coming from different sources to have really good gut microbiome. Yeah.
Thank you, because I knew you were going to be very knowledgeable in that area. And for me, my clients that are on stimulants and on SSRIs, they also sometimes have a difficulty of remembering to eat. And so that's often one thing that we work on. What is a way we can make this routine a little bit easier for you with certain nutritious, maybe not sugary protein bars, but just ample nutrition and fiber throughout the day to help you, to help your medication also help you better. Because what sometimes I'll tell them, and a lot of my clients were at first maybe even resistant to medication, but medication really has a time and place. And I always tell them, I don't prescribe, I have no reason to be biased, but I have seen it make life-saving effects in some of my clients' lives. And when the gut bacteria is healthy and they're taking this medication and they're ensuring that there's no lapses in nutrition, it helps them even more. And so I really think that when done in moderation and tastefully, the medication can be very helpful. I hope that answered.
Jazakallah. We have about 10 more minutes for more questions. Yes.
So I know we were talking about obesity, but the opposite of that, like we also see population, especially younger girls, when it comes to, because they see so much obesity, they're opposed to the idea of eating and they do not get adequate nutrition. So in such a situation, especially as mothers and as caregivers, how do you tell them about this? I know that sometimes they do need professional help also, but when it comes to their nutrition on a daily basis, consuming adequate calories, how do we guide them? How do we get it across them? And that's the question, I guess.
It's a great question. I think that's a question for Mansoora.
So that's a great question. So the question was, how do we make sure that our teenagers, I guess adolescents, are consuming adequate calories, right? Because there is a lot of eating disorders, disordered eating. I don't deal too much with that. I will say mental health and eating are very, very closely linked. I see a lot of my patients, just like Sana said, that nutrition and mental health are related. I do see a lot of that. The guidance that I would give is, everything in moderation. We can't go too low calories and do high exercise, and we can't go, too high calories and then not enough physical activity. So I would just say moderation, as the Quran teaches us, right? Moderation, making sure that we're getting enough, but also letting them know their bodies are still growing. They're going to utilize the calories that they're eating. So reminding them that, and then it's not necessarily, again, it's not necessarily the calories that you're consuming, but where the calories are coming from. Remind them that when you're having calories coming from things that are made from the earth, whole natural foods, your body's utilizing those calories differently. So we have something called thermogenic effect of food. So even as you eat fruits and vegetables, your body's burning calories as it's digesting those foods. And so that could be a way to approach it. When you eat more fruits and vegetables, you're really not eating that many more calories because your body's utilizing them a little bit better. Maybe that approach could work in terms of getting them to eat more nutritious whole foods.
Yes.
I have a question
Okay, good. Yes, please.
He says, I'm a medical student and aspiring sports medicine doctor with a strong interest in nutrition, exercise, and lifestyle. There are so many ingredients allowed by the FDA in foods purchased in the United States, which are banned in most other countries. Can you discuss some of the adverse effects of these ingredients upon our health? Are there steps we can take to combat the use of these ingredients? For example, red 40, petroleum-based things, etc.
Yes, yes. It looks like it's another question for you, Mansoora. Saiba. Yes, so the question is from a gentleman who is asking about his interest in sports medicine and certain foods that are banned in other countries, foods and ingredients that are banned in other countries but allowed in the United States. And if you have something to say, Saifra, also, please. Yes.
I'm really not going to go into specifics about it, but I'll just tell you, just like what I was mentioning earlier, so everything that we're consuming, our body has to process it, digest it, absorb it, and get rid of it, right? And if we're having things that are more natural, that are coming from the earth, our body is able to better use those things. And so I think just remembering that. So every time that you pick up something and you look at a nutrition label and it has 50 ingredients in it, your body's going to have to process all those 50 ingredients. So try to look for things that have, very few ingredients and ingredients that you can recognize. If it says, milk and water and things that we know that are natural, that's a better that's a better food for you to consume. And if it has all of these additives, words that you can't pronounce on there, just think about it. If you love your body, you're not going to be consuming those because your body has to process and utilize all of those things that are coming inside that body. So I hope that answers this question.
Was his question more about policy in the United States?
Also, how we can work to fight against some of those policies
Okay, and that would, Saifra, do you have any insight there?
I'm not well versed directly on those policies, but generally speaking, as someone who's worked in public health misinformation, I will say there is a lot of misinformation about a lot of these things on the internet and social media, and I think to some extent there is almost like it's like a buzzword, like, oh, this thing is really bad for you, but you actually don't know what's in it. And so, again, I'm not saying that I know what policies should be or shouldn't be, and obviously what Mansoora said about whole foods and what's coming from the earth, those things are important, but I would always also caution you to be very careful of what information you're seeing on the internet and online these days. Take some time, if you are someone who's a medical student, to actually look into those journals or those peer-reviewed research studies, because a lot of times the things you're seeing on social media are actually not accurate summaries. It's just someone taking a sentence out of context. You have to look at what is the population that they were studying in that research study. Is that actually something that's comparable, that they're saying now, okay, we can apply this to the general population? Again, not making a statement necessarily on whether we should be for or against Red 40, but just being on the side of, erring on the side of caution when it comes to making statements on what we should or shouldn't do.
Stay here. I actually have a question for you, Saifra. In terms of building in health equity into our interventions, how can we do it more proactively rather than retrospectively or retroactively?
That's a great question. I think it really requires us to do a lot of self-reflection at the start of any of the work that we're doing. And I think one of the things I said at the end of my talk was, decolonize your almost like your mindset. For example, for research, the question is really, who is this research question going to benefit? Is this just going to be some nice report that, USAID can, and I worked with USAID, so that's why I'm saying that USAID can say like, oh, we went in this community and did so and so, but is it actually going to benefit the community in need? Is it actually going to end up causing harm for them? actually including that population of interest at the start. So I think it really, building in equity shouldn't be something that you're like, okay, we've reached this phase, now we need to think about all these factors. It's at the point of, okay, we're going to think about this research. Who are the people we want to work in? Are they historically disadvantaged people? Is there some type of trauma here? Have these communities have mistrust with us because of past research? So even in the example of the Guatemala research that I cited, we were working, a US-based center, but the researcher, the co-researcher, the co-PI on that study was a Guatemalan researcher. I was there training the research team, but the entire training was done by indigenous women from Guatemala. So these were not women with, master's degrees or PhDs. These were just women living in those communities who had an interest in doing research trainings and working with their own communities. And then the information that we gathered, then we did, a lot of focus groups, and we had, it's people from their own community working with them, and I think that's also how you build trust. So it's a process that kind of has to be embedded in every step, and it really has to be part of your thought process at the start. Exactly. And I'm sorry, if I can just answer the question that was about the what kind of guidance the mothers can give. So in Way of the Seekers, there's actually a lot of guidance about food and nutrition, which I didn't know about until I had my own child. So I think there's some really good points in there that we can all reflect on as mothers. Yeah.
I have time for one more question. Yes.
Is there a difference between fiber that is blended versus eating whole or powdered?
Blended fiber versus whole powder, whole fiber. No?
I love this question. Just think about, you repeated the question. So just think about it. Whenever you eat something, a whole natural food, your body has to, as your GI tract is absorbing it, it's like this peristalsis, right? So it goes in and out and it's digesting and absorbing it, right? Whereas if you have it in a blenderized form, it's just kind of going down and it's not being absorbed effectively. So I would say try to get your fiber through whole, natural, real foods because you're going to be doing a lot better for your body. The second thing is they did studies on that, and when you actually eat fiber in the whole natural form, you're actually decreasing your risk of GI cancer. So any of those cancers from all the way from your esophagus all the way down to your large intestine. So just think you're not just benefiting one area, which is fiber, possibly related to decreasing your risk of cardiac disease, but it's actually benefiting you in other ways by decreasing your risk of cancers. So, yeah. Way better to do whole fiber, real fiber from your actual diet. But if your patient's not able to get it through a diet, that's an okay alternative, but I would say try to get it from whole, natural, real foods. The second thing is the probiotics. Oh my gosh. So what I'll tell you about probiotics is please don't do them if you're not eating a healthy diet because they're not going to make any change to your gut microbiome unless you're eating fiber itself. It's only going to build what you already have. And if you don't have anything in there, if you don't have a good gut microbiome to start out with, it's not going to build it if you're not eating enough fiber in your diet. So don't take those pills unless you're eating enough fiber in your diet. So that's what we want to kind of, encourage our patients to do.
So you're talking about Bhatti with the simple conserva?
Yeah, so like all of those, basically, yeah. So we've got a lot of interesting things. Yeah. Yeah, so it does have, unfortunately, it does have saturated fat. Yeah, so that's a misconception. Yeah, that's a big misconception. Same thing with, and yeah, it's 100% saturated. The other thing is the coconut oil. So that's misinformation as well. So a lot of people think that that's healthy, but it's not. Desi ghee. Is desi ghee okay? And it's not. It has saturated fat. Yeah.
My husband has been telling me that there are studies that show that coconut oil, like if you cook rice in coconut oil, it lowers glycemic index. Have you come across that? Is that
So that's very true. So anything in oil is going to lower glycemic glycemic index, and that's just because fat slows digestion, right? So it's going to slow that absorption and that digestion of that of the carbohydrate. So, but it's not that it's good for you. It's just going to slow your, it's going to slow the absorption. Yeah, so you can do, yeah, I mean, you can do a healthier oil. You can use a canola oil or an olive oil instead. It'll do the same thing. The coconut oil is going to have a lot more saturated fat, so it's not good for your heart. So that's why we say, yeah. No more questions, sorry.
I think we're going to have a panel just for Mansoora next year. A lot of good information. Jazakallah again to all of our panelists and to the audience. We're going to wrap up now, and I want to give you a little bit of insight into the rest of the night. We're going to have dinner now. The women will stay in this room. The men will be in Bethesda A and B. That's from 6 to 8 p.m. At 7 p.m., we'll have 3 parallel sessions on career development. The first session is a guest spotlight that is going to be in Delray for men and Arlington for women. The second session is titled Navigating Your Careers in Uncertain Times. That will be in Rugby for men and Auburn for women. And the third session is Building Clinical Confidence, Medical Interview Boot Camp in room Avalon for men and Hampton for women. After that, from 9 to 10 p.m., there will be meetings with the auxiliary heads, Lajna Sadr Dia Bakar Saiba, MK Sadr Missionary Abdullah Dibba Saiba, and Ansarullah Sadr Dr. Mansoor Qureshi Sahib. And this will be happening for Lajna in Bethesda C and D, and for Khudam Avalon, and for Ansar and Bethesda A and B. Yes. Okay, so correction. For the medical interview boot camp, parallel session 3, we'll just be downstairs in one room, not in 2 separate rooms. In Avalon. Okay? Jazakallah again.